Pediatric Emergencies Part 6. In this lecture, we're going to discuss neurological emergencies and psychiatric and behavioral emergencies of the pediatric patient. Neurological emergencies can be benign, which means something like a febrile seizure, or life-threatening, such as a ventricular shunt failure. In order to treat a neurologic emergency, you've got to obtain a thorough past medical history, including previous seizures, shunts, cerebral palsy, or any recent trauma or ingestions. Infants and children are difficult to assess neurologically. Often, they're very uncooperative with your exam due to a lack of understanding or fear. You want to use your pediatric assessment triangle, assess their general appearance, and also seek parents' impression of subtle changes in demeanor and activity level. Conditions that can interfere with mental status include metabolic problems, infectious disease, intracranial structural abnormalities, trauma, hypoxia, or poisonings. A child with altered mental status displays a change in personality, behavior, or responsiveness inappropriate for age. The child may often appear agitated, combative, sleepy, withdrawn, slow to respond, or they may be completely unresponsive. A helpful mnemonic to help you remember common causes of altered mental status is AEIOU tips. You also want to run through your PAT and your ABCDEs quickly, paying attention to disability and dextrose issues. You want to check your glucose, which would be one of the first things that you check with any altered mental status patient. Hypoglycemia is easily treatable. Serum glucose concentration of less than 40 milligrams per deciliter in a newborn or less than 60 milligrams per deciliter in all other infants and children. Your AIOU tips mnemonic: alcohol or acidosis, epilepsy, seizure, endocrine issues or electrolyte issues, insulin issues or hypoglycemia, opiates or other drugs, uremia, trauma, temperature, infection, poisoning, psychogenic causes, or shock, stroke, syncope, space-occupying lesion, or subarachnoid hemorrhage. Assess and support airway and breathing. If hypoglycemic, give glucose. In some patients with altered mental status, you may not be able to do anything but supportive care. But if the child is hypoglycemic, give glucose at a targeted dose of 0.5 to 1 gram per kilogram. Always recheck the blood glucose level after giving IV glucose. And remember, your goal is to maintain normal glucose level. You don't want it to be hyperglycemic for too long because this is associated with worse neurologic outcomes in patients with cerebral ischemia. For children with altered mental status and signs or symptoms suggestive of an opiate toxidrome, you could consider giving naloxone. Transport all altered mental status patients expeditiously. Assess for increased intracranial pressure. Intervene when appropriate. May want to consider adding lidocaine prior to intubation because this may blunt the increase in intracranial pressure associated with the intubation. Signs of increased intracranial pressure include Cushing's triad, which is going to be irregular respirations, hypertension, and bradycardia. When you're intubating a pediatric patient with an altered mental status, etomidate is a common induction agent in septic shock if septic shock is not suspected. Your dose would be 0.3 milligrams per kilogram. Good if patient is hypotensive, less effect on blood pressure than other choices. Other options include midazolam or Versed at 0.1 milligrams per kilogram and ketamine at 2 milligrams per kilogram. Ketamine is actually a bronchodilator, so it's good for patients with respiratory problems. However, it can cause increased bronchorrhea and may cause a transient drop in blood pressure. Muscle relaxants or neuromuscular blockers such as succinylcholine, 1 to 2 milligrams per kilogram, or rocuronium, 1 milligram per kilogram, can be used in the pediatric population as well. If increased intracranial pressure is suggested, adding lidocaine prior to intubation may blunt the increase in intracranial pressure associated with intubation. If you do suspect increased intracranial pressure, elevate the head 30 degrees if cervical spine injury is not suspected. Hyperventilation can lower intracranial pressure temporarily, but this is not a practice that should be used often. Seizures results from abnormal electrical discharges in the brain. Many types of seizures exist. You got generalized seizures, which manifest as abnormal motor activity and an altered level of consciousness. Febrile seizures, partial seizures, these are all different types of seizures. Some children may be predisposed to seizures because of underlying brain abnormalities. Others experience seizures as a result of trauma, metabolic disturbances, ingestion, or infection. The physical manifestation of the seizure will depend on the area of the brain affected. Infants have immature brains, so seizures may be subtle. Repetitive movements such as lip smacking, chewing, and bicycling also suggest seizure activity. Apnea and cyanosis can also be signs of underlying seizure activity. The prognosis is closely linked to the underlying cause. For example, a febrile seizure will not cause brain damage. However, a child who has a seizure as a complication of a head injury or meningitis may have long-term neurological abnormalities. All types of seizures are frightening to caregivers and often are the result of 911 calls. Generalized seizures involve the entire brain. Partial seizures involve only one part of the brain. You have simple partial seizures where the patient will experience no loss of consciousness, and you have complex partial seizures where the patient will experience loss of consciousness. The most common types of seizures are generalized or tonic-clonic seizures, also known as grand mal seizures, which involve the rhythmic jerking of both arms and legs, followed by the increased muscle tone of the tonic phase. Absent seizures, or petit mal, are generalized seizures that involve a brief loss of attention without abnormal body movements. For a febrile seizure, the child must be aged 3 months to 6 years. Febrile seizures occur in about 2% to 5% of all children. For a diagnosis, as I just said, the child must be between age 3 months and 6 years, have a fever, and have no identifiable precipitating cause, such as head injury, ingestion, or meningitis. The strongest predictor is a history of this diagnosis in a first-degree relative. The child's temperature usually increases rapidly to 101.8 or 38.8 degrees Celsius, and the seizure occurs during the temperature rise rather than after a prolonged elevation. You have simple febrile seizures, which are brief generalized tonic-clonic seizures occurring without underlying neurologic abnormalities, and complex febrile seizures. These are longer, focal, or occur with baseline developmental or neurologic abnormality. Simple febrile seizures are brief, generalized tonic-clonic seizures lasting less than 15 minutes. Complex lasts more than 15 minutes. You may see the postictal phase after a febrile seizure. This tends to be brief, so the child will often be waking up or back to baseline by the time you arrive on scene. Depending on agency policy, a well-appearing child with a history consistent with a simple febrile seizure may be transported by EMS or by parents, but always needs urgent physician evaluation. The prognosis with simple febrile seizures is excellent. Rare cases of febrile seizures are ones that last more than 30 minutes and may cause scar tissue in the temporal lobe of the brain. In some of these patients, chronic epilepsy develops, which often can be effectively treated. When assessing a patient with a seizure, you want to pay special attention to compromised oxygenation and ventilation with signs of ongoing seizure activity. Seizures place a child at risk for respiratory distress or failure because of airway obstruction, often from the tongue, aspiration, or depressed respiratory drive. Any child who is having a seizure when you arrive has likely been having a seizure activity for at least 8 to 10 minutes. Consider this child in status epilepticus. Status epilepticus is historically defined as any seizure lasting more than 4 to 5 minutes or consecutive seizures without a return to consciousness between seizures. Refer to your local protocols for guidelines related to how long a seizure can continue before you should intervene. You also want to ask about prior seizures, if they are currently on any type of anticonvulsant or anti-seizure medication, any recent illnesses, injury, or suspected ingestion, how long the seizure has occurred, and the character of the seizure, meaning did we see the characteristic rhythmic jerking, or were there other signs of seizure? Treatment is limited to supportive care if the seizure is stopped by your arrival. Again, you want to optimize oxygenation and ventilation. For an ongoing seizure, your first priority is going to be to open the airway. Also treat hypoglycemia, and then consider administering a benzodiazepine if seizure activity is continuing. Typical benzodiazepine administration may include midazolam or Versed, diazepam or Valium, or Ativan. Meningitis is inflammation or infection of the meninges. There's two types of meningitis: viral meningitis, which is very rarely life-threatening, and bacterial meningitis, which is life-threatening. You should always proceed as if it is bacterial meningitis. But some of the differences between the two: viral meningitis is more common in the summer, and it's usually caused by an enterovirus, and it presents with associated GI symptoms such as vomiting and diarrhea. The children may look and feel quite ill with viral meningitis, however, it is rarely life-threatening. With bacterial meningitis, it is potentially fatal. Children can progress rapidly from mildly ill appearing to coma and even death. In the early stages, it is difficult to tell the type of infection. You should always proceed as if it may be bacterial meningitis. Symptoms vary depending on age and the agent causing the infection. In general, the younger the child, the more vague the symptoms. One of the biggest things that we're concerned about with meningitis is that it may cause sepsis. This could be characterized by a petechial or purpuric rash. A newborn with early bacterial meningitis, their only symptom may be fever. Young infants will often have a fever and perhaps localized signs such as lethargy, irritability, poor feeding, or a bulging fontanelle. Young children rarely show the typical meningeal signs such as nuchal rigidity until they're older. Verbal children often report headaches and neck pain. Altered level of consciousness and seizures are ominous symptoms at any age. Projectile vomiting and photosensitivity are also common findings. Other signs may include Kernig sign. With Kernig sign, the patient cannot extend the leg at the knee when the thigh is flexed because of hamstring stiffness, and Brudzinski sign. Brudzinski sign is passive flexion of the leg on one side causes a similar movement in the opposite leg. Neonates most often contract meningitis causing bacteria during the birthing process. Older infants and young children are at risk for contracting viral meningitis from enteroviruses. Infection control is going to be very important in the treatment of a patient with meningitis. Be sure that you look for signs and symptoms which include fever, altered mental status, bulging fontanelles, photophobia, nuchal rigidity, and shock. Be vigilant about using standard and respiratory precautions. Wear a gown, gloves, and mask if meningitis is a possibility, and also place a mask on the patient. Perform a glucose check on any suspected meningitis patient. Hypoglycemia may result from the hypermetabolic state. For children in physiological unstable condition, provide life-saving interventions as needed and transport quickly. Hydrocephalus results from impaired circulation and absorption of cerebral spinal fluid, leading to increased size of the ventricle. The CSF production rate normally matches the absorption rate, so the net volume of fluid within the brain remains constant. Hydrocephalus occurs in two main forms: normal pressure hydrocephalus, which is a rare condition that occurs in older adults. The mechanism is unclear in this situation. The other type results in increased pressure within the cranial vault. The most common cause of increased intracranial pressure hydrocephalus is the slowed movement of CSF. The most common reason for slowed movement includes congenital malformations in the CSF aqueducts, tumors, trauma, intracranial hemorrhage, and meningitis. Even though movement of CSF decreases, production does not, therefore total CSF volume increases. Hydrocephalus is most commonly seen in children born with congenital brain malformations, also as a complication of prematurity or following surgery for a brain tumor. Signs and symptoms can develop gradually over months or suddenly over days. The signs and symptoms will also vary depending on the cause and the age of the patient. Main symptoms in infants: increased head circumference due to their soft skulls, lethargy, irritability, vomiting, sunsetting eyes, which is a downward deviation of the eyes, tense or bulging fontanelles, and seizures. Symptoms in older children and adults include headache, nausea, projectile vomiting, blurry or double vision, ataxia, poor coordination, memory, and personality impairments. Oftentimes, a cerebral shunt is often used to decrease intracranial pressure. A ventriculoperitoneal, or less commonly, a ventriculoatrial shunt, are basically inserted into the ventricles of the brain by neurosurgeons. VP shunts drain excess fluid from the ventricular system of the brain into the peritoneal cavity through a tube that exits the skull at a valve. VA shunts are similar, except tubing terminates in the right atrium of the heart. Tubing can often be felt in the lateral portion of the neck. In thin or young children, coils of tubing may also be palpable in the abdomen. Draining extra CSF prevents brain herniation. However, there can be complications of the cerebral shunts, which include infection, blockages, and overdrainage. Signs of malfunction of a shunt include vomiting, headache, altered levels of consciousness, and visual changes. In patients with VP shunts, peritonitis can also accompany VP shunt infections. For any of these conditions, manage increased intracranial pressure and transport immediately to a facility with pediatric neurosurgical capabilities. Traumatic brain injury. Head trauma is common in childhood, often minor and not associated with brain injury or long-term sequelae. A small number of children who appear to be at low risk may have an intracranial injury. A number of states have laws requiring medical evaluation prior to allowing children who have been concussed in a sporting event back into play. The goals here are to identify TBI, prevent deterioration, and to prevent secondary injury. Evaluate any child with head injury for signs of potential abuse. Different types of bleeding. You have epidural hematoma. This is going to be hemorrhage into the space between the dura and the skull. It's uncommon in pediatric patients, but they may occur after a low velocity fall. Child abuse accounts for a significant number of cases in infants and children, whereas MVCs account for most epidural hematomas in adolescents. The low incidence in childhood may be because the middle meningeal artery is not embedded in the bone surface of the skull until about 2 years of age. Prompt diagnosis is critical. Patients often present with loss of consciousness or altered mental status. Patients also often report a severe headache accompanied by persistent vomiting or ataxia. Infants may be difficult to console and have a cephalohematoma on exam. Older patients may have what's called the lucid interval, with minimal symptoms after head trauma, followed several hours later by rapid clinical deterioration. A subdural hematoma forms when there is hemorrhage into the potential space between the dura and the arachnoid membranes. Subdural hematoma is fairly common in infants, with a peak incidence between birth and 4 months of age. It often occurs as a result of birth trauma, falls, assaults, or violent shaking. Any infant or toddler with a subdural hematoma should be suspected of having been abused until proven otherwise. Suspect cervical spine injury and take cervical spine precautions. Management includes stabilization of airway, breathing, and circulation, and performing frequent neurologic checks. Pediatric GI emergencies. The first thing on the list is biliary atresia. In biliary atresia, the biliary tract is malformed such that bilirubin cannot be excreted. This leads to liver disease and failure. You want to transport children with massive GI bleeds, obtain IV access, and administer fluid boluses. Viral gastroenteritis, also known as stomach bug or the stomach flu, caused by a variety of viruses, ingestions of certain foods or substances. In most cases, patients will have abdominal discomfort with nausea, vomiting, and diarrhea. May also have accompanying fever. The most dangerous part of viral gastroenteritis in younger children is going to be dehydration. If you suspect dehydration, place an IV line and administer 20 ml per kilogram of an isotonic fluid such as normal saline. Do not administer a bolus with 1/2 normal saline or fluids containing dextrose or potassium. Appendicitis. Appendicitis is common in pediatric patients. If untreated, it can lead to peritonitis, which is the inflammation of the peritoneum, the lining of the abdominal cavity, or shock. Patients typically present with fever and pain on palpation of the right lower abdominal quadrant. Patients often describe the pain as having started in the para-umbilical region and migrating into the right lower quadrant over time, usually hours. Some patients have fever or vomiting. Rebound tenderness may be present, but is not a finding specific to appendicitis. Constipation can also cause severe abdominal pain in children. Pain often follows a meal and is intermittent. Patients have diffuse abdominal pain, but no guarding or rebound tenderness. The severity can often mimic appendicitis. Never assume that you can distinguish between appendicitis and constipation. Transport immediately to the ED. Ingestion of foreign bodies. Foreign bodies lodged in the esophagus causes gagging, vomiting, and difficulty swallowing. Several indications of airway obstruction include difficulty breathing or choking. Keep the child in a calm, comfortable position on a parent's lap and transport immediately to the ED. GI bleeding. GI bleeds are rare in the pediatric population. Causes are often different compared to adults. An important difference because of the rapid transport times in the pediatric GI tract. Ingested upper and lower bleeding may all present with hematochezia or bright red rectal bleeding. In adults, upper bleeding may present as melena or dark black tar-like stools because of the digestion of the blood in the GI tract. In newborns, blood ingested during birth can present as rectal bleeding, seen in the first few days of life, and is harmless. Infants may have blood in their stool if there is maternal bleeding from the nipple during breastfeeding. Children may have rectal bleeding from ingested blood from epistaxis, after surgery such as tonsillectomy, or after multiple episodes of forceful vomiting. Children with constipation can have small anal fissures that present as rectal bleeding as well. Abusive trauma should always be on the differential diagnosis of rectal bleeding in the pediatric patient. Intussusception. This is where the bowel telescopes onto itself. This disease most commonly occurs in children between the ages of 6 months and 6 years. It's commonly the small intestine into the large intestine at the cecum. The patient will present with intermittent severe abdominal pain, lethargy, bloody or current jelly-like stools. Symptomatic management and transport to the hospital. Meckel diverticulum is one of the most common congenital malformations of the small intestines. Patients present with painless rectal bleeding or hematochezia. They present with a rule of 2s. 2% of the population has a 2-to-1 male to female ratio, located within 2 feet of the ileocecal valve, and is commonly 2 centimeters in diameter and 2 inches in length. It contains 2 types of ectopic tissue, pancreatic and gastric, and symptomatic by the age of 2. It can cause concern because of the large volume of blood loss. If you suspect Meckel diverticulum, transport the patient to the ED for further evaluation. Pyloric stenosis. In infants younger than 2 months, pyloric stenosis and malrotation with volvulus are two diseases that cause vomiting and need prompt attention. Pyloric stenosis occurs when the pylorus, the muscle that serves as a one-way valve for contents leaving the stomach, becomes hypertrophied. Infants classically present with projectile vomiting occurring after feeding. Poor weight gain or weight loss, dehydration, and electrolyte abnormalities can be seen due to the amount of vomiting. Surgery is going to be the curative treatment for this. Malrotation with volvulus. This is going to be the twisting of the bowel around its mesenteric attachment to the abdominal wall. Patients present with bilious emesis or dark green emesis, pain, and a distended rigid abdomen. May have blood in the vomitus or stool. It is a surgical emergency and you want to transport immediately to the ED with pediatric capabilities. Consider the following when you're assessing and managing a pediatric patient with GI emergencies: age, gender, whether the child was born premature, current medication use, and history of similar complaints. Assess and reassess location and severity of the abdominal wall, and also give special consideration to patients with gastrostomy tubes. Also wanted to just mention, if a G tube does come out, it's not a big deal. You want to either just put something over the opening of the G tube, or you can attempt to replace it by lubricating the tube in being inserted. Gently press to slide the tube into the stoma, then tape the replacement into place and transport for definitive replacement. And lastly, if you suspect that a patient has dehydration in GI emergencies, to help you determine this, you want to ask, how many wet diapers has the child had today? Is your child tolerating liquids? How many times has your child had diarrhea? When he or she cries, are there tears present? If you suspect any type of abdominal emergency, you want to give nothing to eat or drink until a thorough assessment can be completed. Vascular access is often indicated with signs of clinical dehydration. You should keep the patient comfortable on cardiorespiratory monitors with frequent assessment for change in hemodynamic status. This concludes the Pediatric Emergencies lecture on neuroemergencies and GI emergencies. If you have any questions, please email me, nickray@suscc.edu.